Hello, my name is Dr. Elizabeth Phillips, and I'm a GP partner at Springfield Surgery in Birmingham. I'm going to be speaking today about my experience of being part of the Daffodil Standards pilot, looking particularly at Standard 8 and how it can be used as a compassion tool within practice. I first came across the Daffodil Standards after reading about the new UK General Practice Core Standards for Advanced Illness and End-of-Life Care in the BJGP in March 2018. Having worked through the Gold Standards framework at our surgery, I was excited to see what new things we could be doing to improve our care. So I emailed the author and completed an application to join the pilot for the Daffodil Standards developed by the RCGP in collaboration with Marie Curie. I was immediately struck by Standard 8, general practice being hubs within compassionate communities, and volunteered to pilot this standard. To me, this was at the heart of everything we are trying to do when we are trying to improve end-of-life care in general practice. In my practice, Springfield Surgery, in an inner-city area of Birmingham, we are trying to be a hub of compassion within the community that we serve. Our compassion doesn't just stay in the practice. It spreads out organically into the community. If we don't get this right, whatever other interventions we put in place, I believe will be meaningless. It reminds me of the NHS change model, which has our shared purpose sitting in the middle, and how important it is for any team undertaking a quality improvement project to have a shared purpose clearly defined from the start. For me, that was why it was so important to start with Standard 8, as this helped our team to understand the purpose of what the standards were ultimately trying to do. If we lose sight of this, the risk is of another set of standards to tick. When implementation of the standards becomes difficult, or a barrier is hit from within or outside the team, this standard provides the purpose to go back to motivate the team to press on. With this in mind, we spent most of our time looking at the first section of the standard. 8.1a, develop the team itself as a compassionate community. In a whole practice team meeting, we thought about compassion, especially in the context of an NHS workplace. We considered first that compassion surprises. That care and compassion may emerge where it is least expected, but also may be endangered where we expect them to be the most. We shouldn't presume that care and compassion are found within an NHS workplace. We worked in groups of mixed team members to think about what compassion is, what a compassionate workplace is, and why a compassionate workplace is important. Claire Gerarda has researched and written about compassion within an NHS workplace. She explains how all organisations are emotional arenas, with pain and suffering generated from outside as part of normal living, and from inside, from the inevitable tensions and conflicts inherent in working collaboratively. Therefore, it is important to understand that value for team members is created or destroyed day to day in the way people interact with each other. This is especially important where positive experiences can mitigate against the emotionally laborious environment that healthcare workers daily work within. More compassion in the workplace leads to less anxiety, increased value, and a better attachment between staff and the organisation. Donna Hicks has spoken in her TEDx Declare Dignity about how conferring dignity to team members within an organisation is essential for building a compassionate workplace and is the foundation for improvement work. She talks about using acknowledgement, justice, accountability, and psychological safety to confer dignity within a team. I found the Compassion at Work Toolkit, which has been developed by the Compassion at Work subgroup of the National Forum for Health and Wellbeing, really helpful in developing some practical ideas within the team. I used it to help me develop a staff survey looking at compassion at work and a compassionate leadership survey for the partners of the practice. I received 15 responses from the staff survey and analysed the responses into themes for each question. What are the most important things for you to feel valued and supported at work? Recognition, approachable management, personal development opportunities, good communication, particularly around shared aims and purpose. How can we show compassion to colleagues affected by bereavement, crisis, and loss? With the recognition that everyone copes differently, and there are stages of grief and loss, practical support and flexibility, good communication, recognition that emotions are a normal part of us, development of a safe space to sit, reflect, or talk. Finally, what ideas could we consider as a team to grow a compassionate culture? A daffodil box was suggested, a way of anonymously recognising value and positive attributes of staff members each month. A compassion room was another idea. Consideration of refurbishing an unused storeroom to be used as a quiet space for people to sit, reflect, and care for each other. And finally, it was suggested that we develop practice narrative reflections around difficult or unexpected deaths. The learning from these discussions and survey were used to develop a practice plan for supporting staff in loss. The GMC document, Caring for Doctors, Caring for Patients, was published late in 2019 and picks up many similar themes. In particular, there are recommendations about compassionate leadership. It highlights that compassionate leadership can be thought of as comprising of 4 elements: attending, understanding, empathising, and helping. The document gives specific details about each of these areas, but here I would like to mention some of the details that struck me. Attending means that suffering is noticed at work and is inquired about by leaders. How often do we do this in our practices? When we lead with understanding, we realise that suffering is often masked by missed deadlines or errors. How often do these lead to helpful discussion about what else may be going on? When we lead with empathy, we remain calm and steady, even in the face of suffering. When we lead in a way that emphasises helping, we create flexible time to cope with suffering, buffering others from overload. How flexible are our organisations when a member of our team is suffering? How can we create effective buffers? Compassionate leadership recognises that compassion is neither weak nor vulnerable. These will be important questions to consider as partners within our practices and as whole practice teams together, as we seek to build our practices as compassionate hubs within our communities. Standard 8.1b is to learn lessons from patients and their carers. Our main piece of work in this area was investigating the concept of a Schwartz round and how this may be possible within the primary care team. As a practice, we were already engaged in significant events, but these were often focused on determining what went well, what didn't go so well, and what could have been done differently. The learning was then confined to a very practical level. However, we need to recognise that when there is a significant or unexpected death within the practice, there is a story that needs to be told and an acknowledgement of the effect upon our emotions and behaviour that, if recognised, helps develop a compassionate culture. Based on the Schwartz round concept, narrative practice uses the concept of storytelling for significant events. The story is told from different perspectives, which could include a carer or family perspective. It is not primarily to consider what went well or what could be improved, but to acknowledge emotions, behaviours, and to facilitate reflections and support within a safe, confidential, and non-judgmental arena. Our first experience of this as a practice team was to consider a recent child suicide. First, a receptionist told the story from her point of view, and then another doctor and I told our stories. This was a very powerful experience and a way of compassionately sharing with the team. It had unexpected positive effects on the team and the opportunity for us to develop a future-orientated story together in the face of dealing with this loss. Primary care networks now offer a great opportunity to develop the concept of narrative practice further, developing peer-to-peer support geographically based around a community. Standard 8.1c looks at utilising wider community resources. I connected with Sharon Hudson, who is the Community and Development Partnership Lead at our local hospice, St Mary's. She has been key to opening up the hospice and connecting with the community to talk about death, dying and grieving. This May, as part of Dying Matters Awareness Week, there was an event at the hospice centred around the theme Curiosity, encouraging people to come and ask the questions they had always wanted to ask about death, dying and grief. She also connected me with Brum Yodo. This is a community collective aiming to encourage and support the people of Birmingham to have open and honest conversations about death, dying and mortality. They organise creative and cultural events, festivals, debates and workshops which anyone can go to, and has been a great community resource for our patients. Taking part in the pilot of Standard 8 of the Daffodil Standards reached much further than improving end-of-life care for our patients. It broke down barriers between team members, opened up dialogue, and actually made a difference to the team and how we practiced. The effect was far bigger as we worked towards developing a compassionate workplace that connected with a compassionate community.